Good afternoon. I'm Isabel. As previously mentioned, I'm going to present my PhD topic. I'm from the gynecology group, which is titled Iron Deficiency Anemia During Pregnancy, Effects on the Offspring. So my supervisor is Nando Raj, and I have a vision that pregnancy can have better outcomes through the early detection of anemia and implementation of nutritional interventions. And I have a mission that is to raise awareness among pregnant patients regarding the effects of iron deficiency anemia. Currently, I have two ongoing projects which are investigating the effects and the associations of iron deficiency anemia on pregnancy outcomes and congenital anomalies. And I'm going to present the first one, which is a systematic review and meta-analysis investigating the impact of iron deficiency anemia on pregnancy outcomes. We have that iron deficiency anemia is the most widespread nutritional deficiency worldwide, and iron deficiency anemias account for over 75% of all anemias during pregnancy. It is well known to be a risk factor for pregnancy outcomes, and these pregnancy outcomes increase the morbidity and mortality for both the patients, the pregnant patients, and the offspring. Anemia in pregnancy is characterized as hemoglobin lower than 11 grams per deciliter in the first and third trimesters and lower than 10.5 in the second trimester, and is also graded as mild, moderate, and severe according to WHO. Some examples of the pregnancy outcomes that we are evaluating are preterm birth, which is characterized by any live birth happening before the 37 weeks of gestation with a prevalence of around 10% worldwide, small for gestational age, which is defined as newborns with a birth weight within the 10th percentile for gestational age, and intrauterine growth restriction, which is characterized by the impoverished fetal growth and has many causes like fetal, maternal, or placental causes. The prevalence ranges from 8 to 10%. Therefore, we aim to identify the interrelations between iron deficiency anemia and pregnancy outcomes, as the previous studies did not evaluate all of the outcomes available. Our clinical question is, does anemia increase the frequency of adverse pregnancy outcomes? Our population is pregnant patients. Our risk factor is anemia. Our outcomes, we included preterm births, spontaneous abortions, IUGRs, more for gestational age, stillbirth, and a few others that came with the yielded results. We hypothesized that anemic pregnant patients have a greater risk of having adverse pregnancy outcomes. Our clinical implications to decrease these adverse pregnancy outcomes by identifying the patients at risk. We conducted a systematic search in 3 databases, which yielded more than 20,000 citations that we narrowed down to 200 citations. And these are the results. I'm going to present the preterm birth results. We have that anemia increased in 62% the chances of having preterm birth, and this was dose-dependent, as you can see by the mild, moderate, and severe anemia. We see that the lower the hemoglobin concentration, the higher is the risk of preterm birth, with severe anemia accounting for 4 times higher risk. However, we also extracted the odds ratio from the studies that had these adjusted models, because as we know, preterm birth can be due to many reasons, not only anemia, but also gestational, also the age of the women or ethnicity, smoking habits. And the studies, they accounted for these variables as well. So we have that, again, the lower the hemoglobin concentration, the higher the risk of preterm birth. However, the risk here is much lower, but still high, 80% higher risk in the severe group, and in the anemic group, 30% higher risk. In small for gestational age, we found that only severe anemia was associated with the risk for the SGA, with a 2.80 times higher risk. However, we could not find adjusted models for this outcome, and we didn't find any other significant result. In stillbirth, we find the severe anemia to be responsible for 3 times higher risk of this outcome, and when we see the adjusted model, it's very similar with a 2.4% increase in the risk and also significant. Intrauterine growth restriction, we found anemia to be associated, so this is accounting for mild, moderate, and severe with a 10% higher chances. And in moderate and severe anemia, it is also found to be a higher risk for the pregnant ladies. So we have severe 3.2 times higher risk and moderate 56%. However, again, in the adjusted model, we do not see this. Neonatal mortality, we found that anemia and severe anemia was responsible for this outcome, and we didn't find anything in the adjusted. And also in perinatal mortality, moderate and severe were associated, and in the adjusted model, not. We conclude that anemia is associated with preterm birth, as we could see in the results, and severe anemia accounted for 2.4 times higher risk of stillbirth. The implication for practice is that we have to detect anemia during pregnancy and investigate the cause and intervene. Our implication for research is that randomized clinical trials are needed with different dosages of iron supplements, and we also have to investigate the anemia during the different trimesters because we have a different results according to the trimesters as well that we didn't include here. We just took all the anemic pregnant ladies during pregnancy. We didn't divide, but there is also some problems regarding the time of measurement. And the second topic is investigating the impact of iron deficiency anemia and congenital anomalies. We have that congenital anomalies, they affect approximately 3 to 6% of the offspring, and they are divided into major and minor anomalies. We have in the major ones neurotube defects, congenital heart disease, and minor congenital anomalies are, for example, absent nails and undescended testes. And the major ones can also be life-threatening. So in 2010, we had over 270,000 deaths due to these anomalies. And we have prevention strategies, for example, prevention for STIs, management of chemicals, avoidance of embryotoxic medications intake, vaccination against rubella, and fortification with micronutrients. It is well established in the literature that micronutrients intake, they decrease the occurrence of neurotube defects. For example, folate deficiency when supplemented lead to better outcomes. However, the scientific literature still lacks clearer results on the impacts of iron deficiency anemia during pregnancy. Therefore, our aim is to identify the interrelations between iron deficiency anemia and congenital anomalies. Our clinical question is, does anemia increase the frequency of developing congenital anomalies? We will investigate the pregnant patients in the first trimester as the congenital anomalies will already been happened by the end of the first trimester. And the risk factor is anemia, and the outcomes are the congenital anomalies, but the major ones. We hypothesize that anemic pregnant women have a greater risk of having major congenital anomalies when compared to the non-anemic. Our clinical implication is to decrease the frequency of major congenital anomalies by identifying patients at risk and implementing nutritional interventions. We have conducted a preliminary research which was conducted in 3 databases and yielded almost 3,000 citations, but we are adjusting the search key to have more results. So currently these are the 2 ongoing projects, and we wish to submit the first one in July and the second in December 2023. I would like to finish my presentation with a quote of Paul Erdős. It is not enough to be at the right place at the right time. You should also have an open mind at the right time. Thank you very much.
I would like to ask, were there any other concomitant disorders in the populations, or were there completely healthy women only with anemia?
We excluded the patients that were not, healthy overall. But the problem was that most of the studies, they did not report clearly what conditions the pregnant ladies had. So it was pretty clear to see, for example, if they were evaluating women with preeclampsia. We excluded those. But in a sample with 1 million patients, probably there will be someone with some other kinds of anemia. And many of these studies, they say, okay, we have a prevalence of 0.something% that would not be that significant in our analysis, and we included those as well. But if the patient population was ill, we wouldn't include them. But yeah.
Thank you.
Thank you for the question.
So you said that we need RCTs, how to improve the anemia in pregnant ladies. Would you detail that a little bit?
Yes. We had only observational studies included. We didn't evaluate the effect of any, iron supplementation, but we could see from observational studies that some of these women, they were supplemented and they didn't improve their hemoglobin status. So they remained to be anemic. Because we had observational studies and not RCTs, but we had some secondary analysis from RCTs that were included. So we could see that even with supplementation, the patients didn't improve. So therefore, we have to investigate the cause of the anemia and, of course, supplement if necessary, if it's related to iron deficiency. I'm not sure if I answered your question. But
Partly, but what I would like to understand is that what kind of randomized control trials you have in mind. You're thinking about the lines of placebo against iron orally or iron orally against iron, different iron orally, those sort of questions I've got in mind.
The best case scenario would be, for example, folate and iron and only folate, so we could see the effects of iron in this supplementation if it's improving the pregnancy outcomes. But there are some studies with this design, but I didn't find that many. Therefore, we wish to have different dosages because mostly one single dosage is given, like it's for people who are not anemic sometimes, for people who are anemic, we can see that from the studies, and maybe they would benefit more with a lower or higher dosage, and this is not really, that investigated. We have a few studies investigating the dosage of iron, but not that many. Thank you.
Were there studies which compared IV and oral iron supplementation?
Which one? I'm sorry?
IV and oral iron supplementation comparison.
The folate and folate plus iron, you mean?
No, iron, oral or IV.
Oral, okay, I see. No, I didn't find any studies with these. It would be also a good idea.